Squamous cell carcinoma is usually highly curable, but the safest treatment depends on whether the tumor is low risk, high risk, or very high risk.
Expert host, this explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Wait, if it's highly curable, why can't we just scrape it off?
Well, that takes us right into Section 1, defining cutaneous squamous cell carcinoma, and what we call the branching path of risk. That is exactly the question we need to answer first. It's totally true that most of these skin cancers, which start in the keratinocyte cells, are cured locally. But just scraping it off could be completely inappropriate, say for an invasive tumor that might invade the nerves or even reach the lymph nodes. Here's the thing you need to remember. The pathology report is really just the label on the box. You have to do a proper risk assessment, which is basically opening that box to see what you're actually dealing with inside. A tiny, sharply defined tumor on your forearm and a recurrent one right near your ear might share the exact same diagnosis name, but they absolutely do not share the same level of danger. We have to treat the risk, not just the name.
And that brings us to Section 2, assessing the cancer's risk. Again, treating the risk, not just the name.
So, let's dive into how we actually assess this. The current National Comprehensive Cancer Network, or NCCN guidelines, separate these tumors into very specific pathways. And get this, just a single high-risk feature automatically bumps that tumor up into a higher-risk treatment plan. For instance, a small tumor on the trunk of your body might sit securely in a lower-risk pattern. But if that exact same tumor is located on the head, neck, hands, or feet, or if it grows larger than 2 centimeters, the risk shoots way up. Depth is a huge factor too. If it invades deeper than 2 millimeters, that completely changes the game. Also, if the tumor involves the nerves, or if the patient happens to have a suppressed immune system, the danger level rises drastically. The intensity of the treatment absolutely has to match these specific features.
Moving right along to Section 3, the Mohs surgery advantage and complete mapped margin control.
This brings us to a really powerful local option for those high-risk, tissue-sensitive, or recurrent tumors. We're talking about Mohs micrographic surgery. The mechanical difference between Mohs and a standard excision is absolutely crucial to understand here. Now, standard excision is a fantastic operation, but standard pathology looks at representative vertical sections of the removed tissue, which basically leaves unexamined intervals between those slices. Mohs surgery works entirely differently. The surgeon removes the visible tumor and then examines the complete mapped peripheral and deep end-face margin during the actual operation. It's a real-time feedback loop. So the surgeon only removes additional tissue in the exact mapped areas where cancer still remains, perfectly preserving the healthy tissue around it.
Okay, let me jump in here again. The mapping sounds great in theory, but does the surgical method actually change survival in very high-risk cases? Like, what happens in the real world when we use vertical section excision instead of complete margin assessment for these dangerous tumors?
That is the exact right question to ask. Let's look at the strongest modern comparative evidence we have. This comes from a 2025 multi-center observational cohort looking specifically at 2,752 NCCN very high-risk CSCCs at 12 sites. When researchers compared Mohs or another complete margin assessment method against standard vertical section excision, the associations were incredibly stark. At 3 years, local recurrence was 5.9% with Mohs and complete margin assessment versus 12.5% with vertical section excision. Lymph node metastasis was 6.0% versus 11.6%, distant metastasis was 1.9% versus 4.3%, and disease-specific death was 3.3% versus 6.2%. Now, it is super important to note that this is an observational cohort, not randomized causal proof, but it shows a strong real-world association where complete margin methods had roughly half the negative outcomes in the very highest risk category. Your margin strategy isn't just a cosmetic detail, it is literally a critical part of cancer control.
Now for Section 4, standard excision and simpler options. Powerful, but only in their lane. Let's be absolutely clear on something. Mohs is not necessary for every single skin cancer. A huge part of evidence-based medicine is knowing exactly when simpler methods reliably fit the problem. Standard excision is an incredibly effective, widely available choice, and it's excellent for carefully selected primary, well-defined, lower-risk tumors. We also have even simpler methods, like ED&C, which is essentially a scrape and burn technique. It's fast, it's effective, but only for a very narrow group of selected small, lower-risk tumors on skin without terminal hair.
The same goes for topical creams. They can be great for selected surface-level in situ disease, but you should never stretch them to try and solve an invasive, high-risk margin problem. These simpler tools are powerful for sure, but they have to stay in their proper lane.
Which brings us to Section 5, Beyond Surgery, Radiation and Drugs to Address Advanced Risk.
So, let's look at the next branch on our map. What happens when the treatment pathway has to extend beyond surgery? Sometimes an operation just isn't medically feasible, or maybe a patient has selected high-risk features even after their surgery is done. This is where radiation and immunotherapy step in. Radiation can effectively treat an entire field without needing to operate, but immunotherapy, it has truly changed advanced care. Take a look at the data from the CPOS trial, which tested a PD-1 blocking antibody called semiplimab as an adjuvant therapy. The results were amazing. They saw a hazard ratio of 0.32, and at 24 months, disease-free survival improved from 64.1% in the placebo group all the way to 87.1% with semiplimab. This proves that for certain very high-risk cases in a postoperative setting, systemic therapies can substantially reduce the chance of microscopic disease returning later down the line.
All these treatments make total sense for the tumor itself, but how does the patient's overall health actually factor into all this? It's a massive factor, and that brings us to high-risk modifiers. Immune suppression is one of the most critical. If a patient has had a solid organ transplant, for example, their immune system is intentionally suppressed. The evidence shows that organ transplant recipients have a drastically elevated skin cancer burden. It dramatically raises the stakes. It means the clinical team has to be so much more deliberate. They need to coordinate with transplant specialists, check lymph nodes carefully, and investigate any pain or numbness that might signal the cancer is invading a nerve. There is absolutely no one-size-fits-all approach here.
Okay, Section 6, Making your treatment decision and mapping your personal pathway.
So how do you take all this complex branching information and actually use it? Well, it comes down to knowing exactly which branch your specific tumor sits on. Whether you're a patient or a referring clinician, you need to ask these key questions. First, is the tumor in situ or is it invasive? What specific feature makes it low, high, or very high risk? How exactly will the complete peripheral and deep margin be examined? And finally, does my immune status or overall health change this plan? Asking these exact questions ensures that the treatment you get matches the true risk of the tumor inside that box, not just the general name on the label. To take action on everything we've covered today, your first next step is to read the complete Skin Trust article on squamous cell carcinoma treatment options online. Second, use this framework to discuss your individual decisions directly with your treating clinician, because remember, this explainer is strictly for general education and it definitely doesn't replace individualized medical planning. And third, if surgery is in your future, go ahead and read the related guide, Do I Need Mohs Surgery for next-level clarity. Expert host Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. Because ultimately, recognizing that we must treat the unique risk of the tumor and not just the name of the diagnosis is the single most powerful step you can take toward a clearer, safer medical decision.